Good afternoon, everyone, and welcome to this eMTIC webinar. eMTIC is the collaboration between the Catharina Hospital, the Maxima Medical Center, Kempenhagen, Royal Philips, and the Technical University of Eindhoven. And we have some very interesting stuff for you today. Actually, we have two distinguished speakers, Massimo and Michi. Yeah. We have Richard Lopata, and they are going to take us through a historical overview, but very much also a travel to the future on an exciting technology, which is ultrasound. And their presentation is called the underdog in radiology that turns into the most popular kid in school, which is aspiring, I would say. You may know ultrasound, maybe from your first baby photos when your mom was still pregnant, or you may remember ultrasound from your inkjet printer, where we have the electrical motion of the inkjet that is created by the sensors that are very much used in this application. You may know ultrasound from bats. You may know ultrasound from communication between animals like dolphins.
Okay, we have some problems with audio, so we can pause.
In a technology that has been improved and improved. So it seems that we hit the limit, but then scientists come up with new ways and extend the applicability of ultrasound very much. So from one sensor to the limits of one sensor and one actuator, to extending it to the limits of multiple sensors and actuators, and then adding signal processing, artificial intelligence, anyhow, an exciting story that we're going to hear. The rules of this webinar are: please mute your microphone and mute your camera so that everyone will focus really on the broadcast. If you have any interesting questions, I will try to collect them during the presentation, so we may have some time at the end to raise those questions, but please put them in the chat window and I will collect them. And now the floor is to Massimo and Richard. Go ahead.
Thank you very much. I heard from the booth that there might be some sound problems. Are they resolved yet? Yes? Okay. So I am the one to kick off today, and I will indeed start with a little bit of a history tale. And if we look back in history, one of the first important discoveries in our field is one made by Lazzaro Spallanzani, who was a physiologist and a priest. And he was very frustrated because when he walked into the wine cellar without a candle, he bumped into walls and pillars, but the bats who also lived there did not. So he thought that they had the sixth sense. This was confirmed when he put blindfolds on the bats, and they still could maneuver in this cellar. However, when he put some candle wax in their ears, then they got into trouble. And then he did some more horrible experiments where he sutured their beaks, and also then they could not maneuver anymore. So he came to the notion of echolocation, using sound waves that are not audible for the human ear, and reflections to locate objects. And in fact, as Kees already mentioned in his introduction, this is more common in nature. Our human ear is good, but it ranges up to 20 kilohertz. So we can hear sounds with frequencies up to 20 kilohertz, but dolphins can go up to 200 kilohertz. We use these same inaudible sound waves, ultrasound, also for medical imaging. However, then we go to the megahertz range. Another important discovery, we know a lot about, we always hear a lot about Marie Curie and nowadays also her sister Irene Curie here at TUE. But Jacques and Pierre, two brothers, were actually the two guys who discovered the piezoelectric effect. They basically hit a piece of quartz with a hammer, and then they saw that they could actually induce a potential difference. Well, that's still the basis for piezoelectric materials to this day. Then in the early 20th century, when there were a couple of wars going on, there were a lot of developments using echolocation in the fields of sonar and radar, but also the first devices were coming to the market for instance, the detection of metal flaws in large objects, such as military equipment, but also large buildings and bridges. It took until the 40s before ultrasound was also used in the body, not for diagnosis, no, as a therapeutic device. People believed that you could cure stomach ulcers with it, and even angina. It was up till the 50s when Rowley came with a submersion ultrasound system. So a person was submerged in a water tank and showed the first pulse echo reflection based images. That never really made it to the clinic up to this day, but in the 60s the first handheld systems came to the market where you could basically perform one-dimensional ultrasound imaging with a transducer, with a piezoelectric crystal in there, and then making sweeps all over the body. However, these images were not easy to interpret, because you might have been wondering, what is the signal, this one-dimensional signal that I'm looking at? Well, it's basically a heart, or a piece of the heart. And it was a Dutch scientist in the 70s, Klaas Bohm from Rotterdam, who thought, well, this is a technique that has so much potential, but the cardiologists are not using it. Why don't I use all my experience in sonar, because he had a military background, to develop a very small device that can do this in 2D. So he created the first linear array transducer that allowed B-mode imaging, as we call it now in 2D, of objects. So here you see a phantom, but he also applied it to the heart. So here you see the first 2D ultrasound movie ever recorded in a heart. Of course, the ribs are in the way, but in the south, in Maastricht, there was another Dutch scientist, Jan Sommer, who developed a nice phased array transducer, originally intended for the brain, that later became the most popular transducer for cardiac imaging. Well, then in the 80s, the first machines in the clinic popped up with 2D imaging, with even real-time Doppler, and they already have the card-like appearance that we still have today, although of course today they look a bit fancier. In the 90s, it was mostly improvements in image quality, to be very concise, but also the start of the digital era. So the entire signal processing chain became digital, but we also saw the introduction of new hardware, broadband transducers, and the first matrix array transducers for 3D imaging. And that means that in summary, when you look at these images, we had a A-line of the heart and a very low quality image in the 70s, that's actually me at the age of -3 months, in 2D, and nowadays we can do a lot better. Here you see an ultrasound from 2011, my eldest son, in 2D, but also nowadays in 3D, and as you can see, these images are fairly accurate. But also the A-line that caused Klaas Bohm to develop the linear array is now replaced by 3D even over time. So we can look at the heart contracting in real time. So from bats, sonar, all the way to image improvements and 3D. And then things tended to, or appeared to be stagnating. Images were so noisy and MR was on the rise that in the mid-90s people thought that ultrasound was outdated. However, in the early 2000s, and 2010s, there were a lot of developments where very new, novel methods were introduced, powered by new developments in hardware, but also in software, which actually opened up a new golden era in ultrasound, in which we are still today. And we are going to discuss a lot of these topics. And the first one will be Doppler, beamforming. So I will now give the chair to my co-presenter.
Thank you, Richard, for this very nice historical introduction. So let's do one step back and look at the way ultrasound images are formed. The basic principle is the transmission of a pulse, and what we do is to register the reflected echoes. And knowing the speed of sound, we can then reconstruct which is in fact the line in front. This is the A mode, and you can do it dynamically, and becomes the motion or M mode. But you can also do it line by line, and therefore cover an entire field of view and reconstruct an image. And this is the well-known B-mode imaging, or brightness mode. As already Richard introduced, thanks to the contribution of Jan Sommer, you can also electronically steer the beam in different directions and therefore span a field of view that is larger, much larger than the transducer, very useful, for instance, to scan the heart from between the ribs. Now, in fact, what we have seen so far is an imaging mode where you have to focus line by line the ultrasonic beam, transmit pulses, and wait that they are received back. Doing imaging and building images this way, what you can achieve is a frame rate of about 50 Hertz. That is already very good, but in the last 10 years, what happened is a real revolution in ultrasound imaging, which is the introduction of plane wave imaging and ultra-fast ultrasound imaging. So what you do now is to transmit a plane wave that will insonify the full field of view, and then you reconstruct the image in receive. So theoretically, you can actually, with just one plane wave, reconstruct the full field of view. Of course, you want to increase the image quality, and therefore you will compound plane waves from different angles. And what you will do is find a compromise between quality and frame rate. But with very high quality nowadays, you can achieve frame rates of above 1 kHz, which is really exceptional and far beyond any other imaging modalities. And this has also opened many possibilities for many modalities and other modalities that you will see in the following part of this presentation. Well, going back to the way the image is formed, basically this is based on delay and sum. So you will receive the echoes back, you apply some delays, and you sum them with weights in order to get rid of some artifacts, and this is called apodization. Where can artificial intelligence play a role? Well, we can integrate it actually in the image formation chain, and what we did, for instance, is to implement a neural network that will dynamically optimize the weights in order to reduce the computational complexity and improve the quality of the images. And you see here these two examples. This is an IVUS catheter, so an intravascular catheter. You can see how by using this dynamic weighting with artificial intelligence, you can improve the quality of the image, even the resolution, at a much lower complexity. Well, this can also be integrated and extended actually to plane waves by doing optimal compounding, also by support of artificial intelligence. And you see with 11 plane waves the quality of the obtained image over there. But in fact, you can also reconstruct images in the radom domain by using the radom transform. And then what you can do, again, is to use artificial intelligence in order to optimally weight the compounded components from a radon transform and optimize the quality of the image. And this is again exploiting the different angles at which you are imaging. And by doing that, Richard's group has actually proven how you can increase in resolution and contrast of the images. Well, a key application of ultrasound is in fact Doppler. What is Doppler ultrasound? Well, what you do is you transmit one ultrasonic pulse hitting a moving target, and then the echo that you receive, the reflected echo, will show a frequency that is shifted. And the frequency shift is the Doppler shift, and this is proportional to the projection of the velocity along the ultrasound line. So what you have is something that is angle dependent, but it's indeed a very nice estimation of velocity that can be used, for instance, for imaging blood flow. And here is indeed a nice example of coronary flow. Now, a multi-gauge system is used, so you can estimate the velocity at different angles and reconstruct the full flow profile, as you can see over here. But ultrasound has developed much further. Of course, if you can do multi-gauge along one line, you can also do through the full field of view and reconstruct an image where the velocity is coded with colors. And this is indeed color Doppler. Of course, the resulting frame rate will be lower because you have to fire many lines, but you will have an image that provides a full picture of the velocity field. You can also set up the filters in a different way and therefore focus on slow-moving structures, like for instance with tissue Doppler. And then this is a great solution in order to image tissue motion. And even further, you can integrate the full Doppler spectrum rather than looking at the frequency shift, and then generate images that are very sensitive to low flow and can be used for looking at perfusion. And here you see a nice example, for instance, of renal perfusion. Now, these are all great possibilities, and we have also to support the doctors with the problem of the angle dependency. What we have developed in our group, also supported by AI, is that by fitting an ellipse, for instance, around the cross-section of the carotid, then you can reconstruct the angle and allow the doctor actually with a free angle, so free hand in the cross-sectional section, to absolutely measure the blood velocity and the velocity profile, the same as you would do actually with a longitudinal view that is very carefully aligned with the vessel. One of the key applications of Doppler, as was already in the introduction by Case, is pregnancy. So as you can see here, this is cardiotocography, where an ultrasound beam very large is used to invest the heart, and the motion of the heart will actually generate the Doppler shift that we measure in order to estimate the heart rate. However, fortunately, the fetus is also moving when it's in a good condition. As a result of that, we very often lose a miss signal by this recording, and the intervention is needed. So what we developed is actually a larger matrix that can cover the full abdomen, and then by advanced signal analysis we can track the position of the fetus and adjust the beam in order to follow the fetal heart. Well, what we have seen so far is Doppler line by line. As I told you, this allows actually the reception of a limited number of, the acquisition of a limited number of samples, and this gives limitations also in terms of resolution to set up and optimize the filters. But what has been developed also in line with the ultrafast imaging revolution is ultrafast Doppler. By doing this, you can acquire really large amount of samples, improve the signal-to-noise ratio, set the filters much better, and you can obtain then these much better images, where you can see here, for instance, all the circulation in the heart, in the brain, with a much higher resolution. But even further, there has been developed, as you can see over here, by ultrafast Doppler, and looking, for instance, through the fontanelle. Here you see a beautiful reconstruction of the perfusion in the brain, and with even the possibility to detect the onset of epileptic seizures. And you see down here also the possibility to look actually at the vector, the direction of flow. But how is that possible? Then that actually was a breakthrough introduced by the group of Jensen DTU. So if you look at these images, in fact, there is a presence of a vortex, but it's very difficult to detect it because of the directionality of Doppler analysis. Well, what he did is to introduce the concept of transverse oscillation. So by using specific apodization with two sources of ultrasound, you can generate an interference pattern between ultrasonic waves that will generate transverse oscillation laterally, and therefore allow for estimating the velocity in both longitudinal and transversal direction. And the result is that you can obtain these beautiful images where then you see that the vortex is now clearly visible. And this has also been, in fact, extended in 3D nowadays. You see this very nice animation. Well, and now I leave the word back to Richard to talk about elastography.
Thank you, Massimo. So next topic is also a functional imaging modality called elastography. Because sometimes we are looking for contrast between different tissue types that is not showing up in the ultrasound images. So the gray values are the same. And you could think of a tumor in an organ or a plaque in an atherosclerotic artery, or maybe you want to assess what bigger region is affected by a cardiac infarction. And then we actually resort to one of the most ancient techniques used in medicine, which is palpation. So you palpate the tissue and then you are going to look for regions that feel stiffer, like a nodule. And we can do that also with ultrasound. And what you then will see is that tissues that appear the same in an image, so the same gray value, will actually have a completely different elasticity value, which we call the shear modulus or the Young's modulus, but I won't go into specifics here. It was actually Ophir in 91 who thought, well, this palpation we can also do with an ultrasound device. He took an ultrasound transducer, he pushed the tissue under it, and he was recording ultrasound data, the raw data or the process data, while pushing. And what he then, as a core technique, used was time delay estimation, which basically yields us the displacement of the tissue under the transducer. And because of the high resolution of ultrasound, we have this spatial displacement field in such a high precision that we can actually derive the strain from that. And with some very rough and also largely inaccurate assumptions, we can also then produce an image that resembles elasticity by basically inverting the strains. And this technique he developed, and this is the first elastogram ever shown by Ophir. So you have a phantom in the middle, a softer layer. He pushed it with the transducer. On the left you see the ultrasound image. You can see the layer, he did that on purpose. But on the right you can also see the contrast because the strain in the softer layer is much higher than the surrounding two. And this technique found its way into the clinic. So we now can use it, it's on clinical scanners, for instance for tumor detection. So on the left you see an invasive ductal carcinoma in the breast, and you see the grayscale appearance in the left panel, but in the right you also see the strain image, and you can see that the strains are very low. It's a dark region, it even extends a little bit with this arm on the side, over here, and that means that this is probably a malignant tumor because these tend to be stiffer. And on the right you see a similar example in the prostate, where actually the tumor lights up quite well in the strain image, but not so in the sonogram. This is all very qualitative because you have strain and it tells you if something is soft or hard. If you want to do quantitative elastography, a very nice technique, and also I guess a breakthrough technique, was developed in the early 2010s by Berkov et al., which is called Supersonic shearwave imaging. There you focus the ultrasound, you create an acoustic radiation force, you push the tissue, and as a result a shear wave will propagate in the transverse direction. And then with this ultra-fast imaging that Massimo just discussed, we can actually image the tissue at a very high frame rate, at such high speed that we can follow this shear wave through the tissue. And here are two nice movies from that group. On the left, a homogeneous phantom, and you see the shear wave propagating, and on the right, a phantom, also again with an inclusion, so you see the wavefront being distorted. If you track the wavefront, you know the shear speed, and if you know the shear speed, you can actually calculate the elasticity parameter, the Young's modulus. So now you can see, again, this inclusion in the elastogram, but even with a numerical value for the elasticity. And not only the contrast is better, we also have now quantitative numbers. This technique can also be used for tumor detection, and here you see a very clear example with a ductal carcinoma on the left, which is much stiffer, so it's a malignant tumor, and a fibroadenoma, which is benign on the right, with a much lower modulus. And in the B-mode images you can see that the appearance on B-mode is not that different, but in the elastograms they are. And nowadays, even with AI, you can also estimate these modulograms directly from B-mode. Of course, strain imaging was not thrown overboard completely because there are also structures in the body that are deforming or are being deformed. And a prime example is, of course, the heart. So cardiac strain imaging is a quite large field where the deformation patterns in the heart are measured, and are even now clinical parameters being used by cardiologists. If you use the processed ultrasound data, you can get general strains. So here you see 6 strain regions that have the same color, so it's very global. But if you use the unprocessed data and some more intelligent software, you can actually create maps of local deformation, and then you can even see the deformation pattern propagating through the heart in these images. Well, this is in 2D, but we can also do this in 3D. And nowadays with ultra-fast imaging, also at relatively high frame rates. A limitation that Doppler used to have is that these measurements are very accurate in the direction of sound wave propagation, which we call the axial direction. And in the other direction, the quality of these strains and elasticity assessments is quite low. The solution is again to steer the sound, because then you're basically changing the direction of the sound propagation, and you have a much better strain image, as shown in this vascular phantom on the right, where you see the B mode of the phantom pulsating, and then the first strain image is with compounding of these steered ultrasound waves, which is a much smoother strain image than the one on the bottom with a conventional technique. However, there are also some organs and arteries that are located too deep for steering to be effective. There is no overlapping region anymore, or the angles of steering are very small that it doesn't yield us any accuracy. And that's something that I will discuss later. So I will put a little cliffhanger here. Now I give the floor back to Massimo.
Thank you, Richard. Let's now discuss the additional possibilities that are given by the use of ultrasound contrast agents. So ultrasound contrast agents are in fact microbubbles with a size between 1 and 10 microns. These are shelled in a phospholipidic shell in order to make them more stable. And most importantly, they scatter ultrasound non-linearly. So this gives actually the opportunity to image these microbubbles with contrast-specific imaging sequences. They can highlight the signal from the microbubbles while suppressing signal from tissue, as you can see in this power modulation on the right-hand plot. Now, what was the first application of ultrasound contrast agents? This was actually left ventricular opacification, and it was intended in order to delineate more accurately the ventricle and therefore estimate central parameters like the ejection fraction or even detect the presence of clots. If you look at these images, in fact, you see that the contour is not so well delineated, and therefore ultrasound contrast agents were used, and now you see, like the dark line that represents tissue, how more easily you can delineate the actual contour of the ventricle, and you can even spot, in fact, the presence of a clot over here that was totally invisible by standard B-mode ultrasound. So this is really a great advantage provided by ultrasound contrast agents. But even further, what was developed, especially in the area of cardiology, is a technique for myocardial perfusion, which is the distraction replenishment technique. So unique of ultrasound contrast agents is that if you use a high pressure burst with ultrasound, you can destroy the microbubbles. And then you look at the replenishment of these microbubbles across the distraction plane. And this can be modeled with an exponential function so as to estimate, in fact, the local perfusion of the myocardium. But the most wide application of ultrasound contrast agents nowadays is in fact in radiology, and for instance for the detection of liver cancer, of hepatocellular carcinoma. As you can see here, the advantage of ultrasound contrast agents is that you can easily detect the faster wash-in and faster wash-out of the agent. So in this case, you can very easily, in fact, pinpoint the lesion over here. But this is qualitative. What we introduce in our group is, in fact, quantitative ultrasound contrast ultrasound analysis, and this is by introducing the concept of contrast agent dispersion by contrast ultrasound dispersion imaging. So what we do is that we look at the dispersion of the microbubbles through the microvascular bed, and this actually allows inferring the underlying microvascular architecture that changes because of cancer angiogenesis, and therefore this is a tool in order to detect cancer. In particular, we apply this on prostate cancer, and you see these dispersion maps, how good they actually agree with the ground truth given by the histology. But the most important study was in fact done in 142 patients where we targeted biopsies based on QD. So these patients first the prostate, as you can see in this video, was delineated in order to register it and know exactly how to target biopsies and where to analyze the images. Then the contrast agent was prepared and injected in the patient. And what we will see then is, again, the wash-in and wash-out of ultrasound contrast agents, as you can see over here, through the prostate. Then, based on QD analysis, you can detect where the areas are where suspicion of cancer is present. And only there, then, biopsies will be taken. Well, we achieved the detection rate, which is actually comparable to that of the much more expensive multiparametric MRI. So very, very promising results what we obtained by QD. But as you have already seen, ultrasound developed also in 3D, and therefore we also developed QD in 3D. You see here this reconstruction of dispersion maps in 3D. And this also gives the possibility actually to use tractographic techniques similar to what you would use in brain MRI and reconstruct the main bloodstream through the prostate. And you see how those are also well in agreement with the histological result. But if you really like, in fact, to look at microvessels, then the research was inspired by research in optics and the Nobel Prize by Eric Bezek. And what was introduced in 2015 is ultrasound localization microscopy. The basic principle is that you can, at very low concentration of microbubbles, isolate individual microbubbles and then detect and pinpoint the position of each microbubble, and therefore you achieve virtually the resolution of the size of a microbubble once you know the point spread function of your imaging system. A lot of research has been done in this field, so with different approaches. And in fact, what we have been experiencing are beautiful results and beautiful images. You see this image of a rat brain is really impressive, where all the tiniest microvessel can be highlighted. However, this technique is limited by the fact that you have to use a very low concentration of agents. That means that to feed all the microvessels, you have to scan for a long time. And as you want to scan actually at the micro scale resolution, you will be very sensitive to motion artifacts. So this technique is not really ready for being transferred into the clinic. So we contributed to this by developing actually a deep learning approach where the individual microbubbles could be also isolated when the point spread function is overlapped, so at higher concentrations. So this network worked, in fact, very efficiently and allowed, for instance, to reconstruct the circulation of these the spine of a rat, actually with very tiny details, with just 8-second registration. And the research is still progressing, and actually the first steps in the clinic are being made, and you see these beautiful, in fact, images that are coming from a human brain through the temporal window, and you see the reconstruction actually of the tiniest microvessels by this technique. So it's virtually an extremely high resolution that you can obtain by ultrasound localization microscopy. Well, with ultrasound contrast agents you can go even further, and microbubbles can be decorated with ligands that bind to expressions of, for instance, inflammatory tissue or even cancer, and therefore stick to this type of tissue. This can be used and has been used in cancer. These are the very first images at the IMC in Amsterdam, where if you wait for about 10 minutes, then you see the accumulation of the microbubbles, targeted microbubbles, to the vascular endothelial growth factor receptor 2, which is overexpressed in angiogenesis. This was done by using BR55 agent. But this is a qualitative analysis. What we developed is more quantitative analysis, whereby just looking at the first minute or even less of the recording, you can estimate the binding rate of these targeted microbubbles and therefore detect the presence of cancer, as you can see in this animal model of prostate cancer. Now, we have seen also from the presentation of Richard all the potential of ultrasound to produce several complementary parameters that can be very useful, especially for the diagnosis of cancer, which is a very complex process. We can look at molecular expressions, angiogenesis, and mechanical characterization of tissue. So the next step is, in fact, to combine all these parameters together in order to boost the accuracy of our diagnosis. And this can be done, in fact, by the support of artificial intelligence. So what we have done is, for instance, the first steps in the area of prostate cancer detection by comparing shearwave, elastography, QD, and contrast ultrasound with B mode compared to the histology, which is really an excellent result and a very good agreement. And this was even further extended to 3D, although the reference here was just given by biopsies and not the full histology. Still, the results are extremely promising. Now I'll give the word back to Richard.
Thank you. So we've seen quite some applications, and the question is what more can we add to the equation? And one topic that I want to discuss is large aperture imaging. Because ultrasound has still its limitations. The field of view compared to CT or MRI is of course rather limited, and also the penetration depth. But also in 3D, the temporal resolution on clinical scanners is still moderate, although in literature we see also high frame rate imaging making its entrance there. But if we look at our images, one thing will always remain, and that is this anisotropic contrast and resolution in our images. And that is caused again by the fact that we have very high resolution and contrast in the direction of sound propagation, the actual direction, and moderate to poor in the other directions. And that will affect not only the quality of our images, but also our geometrical measurements or functional measurements that we perform on these data. So we need to beat these physical limitations of ultrasound. And one way to beat this is actually to go from very handheld devices to much bigger transducers. You could think of a large array with multiple elements or with multiple apertures. Or you could use multiple probes at the same time. And already some work has been done in that area, first starting with moving the probe when imaging a large organ. For instance, the aorta in your abdomen is the largest blood vessel in your body. And if you want to image, for instance, an aneurysm in this aorta, the normal field of view in 2D or 3D will not suffice. So then what we can do is record images at different instrumentification sites and then stitch these images together and then capture the whole geometry of the aneurysm. You could also do that in the other direction. So move the probe and keep the imaging plane rather constant. That's not to expand the field of view, but actually to improve resolution and contrast. So if we would image this aorta normally with a single probe, this is typically the image that you would get. The total image is on the bottom and the zoomed one on the top. But if we do this from multiple instrumentification sites, we merge these data together, then you see that the contrast improves of our image and also even of the spine that lies below it. Now this we can do in 3D as well. So either expand the field of view or improve our contrast. And we can even use these data to improve the temporal resolution. Again, the temporal resolution is rather moderate, so it's 5 to 15 Hertz volume rate. But what we can do is measure for a longer period in time. And then we have smart signal processing techniques. We can actually more or less, well, let's call it, sort the data and then produce a 3D volume that has a relatively good frame rate of 20 to 40 Hertz. But ultimately, what we want to do is not image an organ at different points in time from different positions, but have a multi-aperture system. This is one of our prototypes where we actually have 2 curved arrays that can operate in an interleaved fashion. So probe 1 creates an image, then probe 2, and then we can combine these data, as you can see in the combined image in the bottom, and you immediately see that the total aorta has a much more homogeneous appearance than in the single images. And then coming back to elastography and my cliffhanger, what we also can see is that if we then perform elastography, so strain imaging on these data, if we compare a normal ultrasound image on the left or the combined elastogram on the right, you can see that the quality is enhanced in a large section of the total circumference of the aorta. If we have multiple apertures, it would of course be a waste of possibilities if we would not use them at the same time. What we can do is transmit with one probe and receive with that probe and then switch to the other one, or we receive with both. In that way, we not only receive the backscattered ultrasound with the probe that was transmitting the sound, but also, let's call it the side-scattered ultrasound with another probe. And that's what we call bistatic dual aperture imaging. And here you see the evolution from a normal ultrasound image on the left of the aorta, the dual aperture image of the aorta that I just shown on the previous slides, and then on the right you see the fully combined bistatic ultrasound image of the aorta using the received data from both probes. And you can see that again the image quality improves. Here are 2 other examples. You see that not only the aorta but also the surrounding tissue now has a much better contrast. Also the strain imaging. So if we already had a big advancement in vascular elastography using this dual aperture system, but with bistatic we also can estimate the displacements with even higher accuracy and precision and generate these strain images. And it's also the first time that we can measure the radial strains in the wall thickness direction with ultrasound. Of course, the aorta is quite static. Just to show you that this also works in more complex organs, this is the heart. And with a similar technique, we've also recently proven that you can apply this technique in, largely deforming structure, such as the heart. What's the next step? That's going to 3D. So this is a bit of a premiere. So here we see one of the first 3D bistatic ultrasound images also acquired in this porcine setup that we have. This is all preclinical work, and we hope to extend this in the near future. And the last topic that we will discuss today is also a very exciting field in ultrasound called photoacoustics. Up to now we have seen that ultrasound was used to transmit waves and then we create images from the received reflected waves. But you can also create ultrasound by sending in light. So here you see 2 objects, and let's assume that these 2 objects like to absorb light at a certain wavelength. If we then transmit a pulse with that wavelength, the sound will be absorbed. That causes this tissue to expand, then collapse again, and that causes an ultrasonic shock wave that propagates through your tissue. We can then receive it with a normal ultrasound probe and then perform image reconstruction as we normally do with ultrasound, and then you get a photoacoustic image where we now only see the 2 objects that absorbed this light. So we basically have optical contrast with the resolution of ultrasound. Well, that was primarily up to now a technique used in more microscopic experimental studies. So here you see a study in a tumor model where they could image the tumor vasculature all the way to single blood cell level. But nowadays it's more and more being applied also in vivo. However, to go into the clinic, where it's not widely applied yet, we need to get away from these bulky and expensive lasers that we typically use and are also typically not integrated with the ultrasound device. So in projects, typically, or recently, we see a lot of developments where new handheld systems are being developed with the optics integrated with the ultrasonics. And when we have these devices and we choose our wavelengths of light wisely, we can actually perform non-invasive spectroscopy with photoacoustics. So we can send out different pulses with different wavelengths, get the received ultrasound that's generated because of the photoacoustic effect, and then distinguish between different tissue types, as is illustrated here quite basically in this animation on identifying the content of atherosclerotic plaques. Well, to show that in real life, here is an example. Here you have 3 plaques that were taken out during surgery. The ultrasound images are in gray, the photoacoustics in red-orange, and we see certain regions light up in the photoacoustic measurements. And we use the wavelength here that is applicable or is being absorbed by blood or hemorrhages. And when we indeed then compare our images to histology, we see that the signals came from regions where there were intraplaque hemorrhages, a very important marker for rupture risk of these plaques. Well, the next step is of course to do this in vivo, something we've done with the Catherine Hospital, and then we do the same measurements during surgery. Penetration depth is still an issue with light, so we do it during surgery when the neck is opened. Here is a nice example of an artery beading. You see the lesion, and when the surgeon cut it open, it appeared that there was a big hemorrhage on the top part of the artery, and it also showed up in our photoacoustic image. And in fact, what we see is if a plaque is not vulnerable, we get very clean, distinct photoacoustic signals, and we get more diffuse PA signals in vulnerable plaques throughout the vessel wall. And this can even be miniaturized to intravascular ultrasound and then applied in the coronary arteries to look at stenosis there. And the last example that I want to show you with this new exciting technique, also spectroscopy type of analysis, is on cartilage damage. Of course, cartilage damage is a huge problem. It affects 10% of our world's aging population, and it causes pain and a loss of mobility. And what we want to know is, at an early stage, how is the damage developing? And what we've shown recently with photoacoustics is that we can actually map the spectroscopic response of cartilage with photoacoustics. And then we saw that different types of damage, different levels or degrees of damage, actually show different spectral properties. And this allowed us to create a sort of damage map which corresponded very well with histology. So this damage map could in the future be a new imaging modality for an orthopedic surgeon to guide or plan surgery. All right, so that was the last topic. Now we go to the last part of this presentation. I was allowed to discuss the past, and now Massimo will discuss the future.
Yes, thank you. It's really an honor of, after all this overview of huge advances in the ultrasonic field, also to discuss with you what can be the vision and the future of ultrasound, which we actually see very bright. So the first the first shot that I would like to give is actually based on the digital twins. So you have probably all heard about this. So it's about developing models that can be developed and become patient-specific once they are, in fact, combined with multi-parametric acquisitions. They can be done, in fact, by ultrasound. So, in fact, ultrasound provides a great opportunity for developing these models and to, in fact, improve our diagnostics based on the combination of ultrasound with these models. You see here from Richard's group a beautiful example of an aortic aneurysm. Well, we have discussed, in fact, about the possibility of ultrasound to produce a huge amount of different complementary parameters related to the different aspects that can be used, in fact, for instance, the diagnosis of complex diseases like cancer. Well, what we can foresee in the future, together also again with advances in artificial intelligence, machine learning and deep learning, is that actually we could map this parametric space also onto gene profiling and genomics. So this will allow us to make the step from diagnostic ultrasound to even prognostic ultrasound and be able to use ultrasound and therefore have a non-invasive tool which can be used and for monitoring, for instance, cancer treatment, especially to predict the response to treatment and even optimize the treatment non-invasively without the need for biopsies. Now, ultrasound, now we have seen it especially as a tool that is a diagnostic tool, but in fact it can also be an interventional tool. So ultrasound is very suitable also for being used in operating room. And what we are currently developing is in fact again a multi-parametric approach that can be used, supported by AI and therefore a reinforcement learning framework in order to optimally characterize tissue in real time, provide feedback in order to monitor the ablation procedure in atrial fibrillation, for instance. And of course, this can be used for planning and for monitoring as well. But ultrasound is in fact not limited only to monitor treatment, but can also be used for treatment. In fact, if you use high-intensity focused ultrasound, this can be used to produce ablation on itself in a minimal invasive way with respect to other techniques. It can also be used for sonothrombolysis, so for the dissolution of clots, which is a very critical application. Nowadays, also research is developing in the direction of neuromodulation and opening the blood-brain barrier, which will help a lot, in fact, to providing treatment to the brain and so be more effective in the uptake of drugs in the brain. Now, along this direction, we have seen the use of targeted ultrasound contrast agents, but ultrasound contrast agents, besides being targeted, have also the advantage of being, in fact, of the possibility of collapse. So they could actually be loaded with genes or drugs, for instance, and using high pressure bursts by ultrasound in order to burst the microbubbles, and by cavitation the drug will be locally released where the microbubbles are selectively bound, and moreover their cavitation will produce microjet that opens the cell membrane and therefore even favors further the uptake of the drug locally. So you can imagine that, for instance, for chemotherapy, these are in fact really a great groundbreaking developments in the field. Well, besides treatment, we have also experienced in the past years the development of ultrasound as a pocket device, something that you can in fact have implemented in your mobile phone. You just connect the probe and you can scan. So this is something really unbelievable if you think of the bulky scanners that are usually used in the hospital, for instance, for CT or MRI. And this can also be, is now even developed with a wireless solution. So this is extremely suitable for point-of-care ultrasound, which can be done in peripheral centers, very local centers, so not necessarily in high-care centers. And therefore, the diagnostic potential of ultrasound can be distributed all over the place without need for being fully centralized. And this will also help the healthcare system. Actually, even a further step is to make it wearable. And this is a marathon that was fully recorded by Richard's group using a new Sonos system. So the muscle could be monitored over time and fatigue as well. So these are really important steps towards using ultrasound as a wearable device that can continuously monitor patients. And even more revolutionary steps have been made this year with the introduction of this really thin patch of a matrix of ultrasound transducer that can be placed on the carotid in order to continuously monitor flow and pressure over time. So these are really amazing revolutions that are happening nowadays, and they can really allow continuous imaging and continuous monitoring by imaging solutions. And even further, nowadays we can even ingest an ultrasonic pill and monitor from inside. So the vision that we have developed with Richard and together also with all the Dutch community in ultrasound is this everywhere concept that we have submitted as a very large proposal. It's about medical imaging for everyone, anywhere and anytime. So this in fact is the transition from a central scanner where patients have to queue in order to be assisted to actually moving the scanner to patients thanks to the use of these large matrices of transducers that can be in fact developed in the form of a patch and empowered by cloud computing with the support of AI. So these are really major advances that we foresee in the future that will certainly impact the healthcare system in a very positive way. So if we look globally at the impact that ultrasound can have on the healthcare continuum and the contribution that it can give it from the point of care position, so really early diagnosis in order to have also possibly early treatment. So early diagnosis in point of care treatment and advanced diagnostics if necessary, also in the hospital, up to the use of ultrasound for treatment. We have seen either monitoring treatment with, for instance, catheter transducers, or even, in fact, doing treatment itself with high intensity focus ultrasound, and eventually favor the offload of the hospitals by earlier moving the patients home, thanks to the possibility of continuously monitor and image patients outside the hospital. So I hope that all together I have convinced you about, and we have convinced you about, the great potential that ultrasound has and the impact and the contribution that it can give to the healthcare system, being in fact a cost-effective device of high quality that in the future can also be developed towards a wearable device. Thank you.
Thank you very much, gentlemen. Impressive timing. I didn't believe that you would catch all this story in 50 minutes, but you did it.
We didn't believe either.
I think there's a lot of inspiration. And I don't think you have finished, because what I understand is the future is starting now.
Yes.
I will take my laptop. Maybe there are some interesting questions from the audience. If you have any questions, please type them in the chat window so that I can ask them. We have a few minutes.
Yeah.
I have one question for you regarding the training of digital twins, because I think the interpretation of the picture is still quite difficult. What do you see actually? So you need a lot of physical knowledge and maybe clinical knowledge to interpret those things. So how are you going to train
this is
your models?
Question for you.
Well, of course, that would mean ground truth data. So it means that we have to resort to the experts in the field, which are the clinicians and the radiologists.
Yeah.
We have both groups have very good connection, for instance, to the Catherine Hospital and the Maximum Medical Center, where we have large studies, either prostate cancer or abdominal aortic aneurysms, where we generate a lot of information, clinical data, and in the end, that's what you need. You need a bit of volume. But you could also think of ground truth data in silico, so simulation frameworks that we also have developed, where you know the ground truth, and then you simulate the ultrasound images, and then you train the network using the ground truth as input.
Yeah. Of course, this very much relates to the way of working in eMTIC, where we have the complete value chain working together.
Yeah, exactly.
Yeah, I think we have some questions. No, this is just, I think, a stimulus for the future. I simply want to add my warmest congratulations for a very impressive presentation, a very informative presentation. Yeah. Are there any other questions? Now, maybe, Massimo, what is your main challenge? We see that the whole field is moving more and more towards signal processing and intelligence. Is there still something to improve or to gain in the transducer area?
Absolutely. So the developments that we have seen here in the vision on in fact, thin film transducers, this is happening right now. It's not really something that is off the shelf available commercially nowadays. So this is really state-of-the-art research and not devices that are nowadays becoming available. There are actually different competing techniques in this area, and it's still not really sure which one will win the game. You can use PCT transducer, but you can also use CMOT transducers, and we'll see what is actually the most suited solution for wearable devices.
Being developed with nanotechnology or not?
Well, there are also some alternatives to PCT transducer, but if you look also at the PMOT transducer, they are still based on PCT technology. So that is still the leading technology in the field, but the use of capacitive micro machine ultrasound sensors, so the CMOT, that is also an alternative technology that can be very competitive, also to the advantage that, because of the advantage that you can tune the frequency and therefore span a much larger, let's say, range of applications with the same transducer.
And different form factors. So they can be big, they can be stretchable, flexible, broadband, narrowband.
It's incredible. I could not imagine this when I was doing my studies. There was one group working on piezoelectric materials, but this is incredible what is still possible for the future.
Other important developments are in the electronics that can nowadays also be made flexible and so have a monolithic integration of transducer and electronics. But the main challenge, as you were asking about challenges of these solutions, is that compared to standard transducers, where you know the position of the elements, Now with a flexible patch, of course, that information is lost. So you really need adaptive signal processing. Here is where signal processing becomes really relevant in order to also to estimate the relative position of the of the elements and optimize the image quality.
Yeah. Some questions coming in. Do you see connections between ultrasound and other imaging or monitoring modalities, and what do you consider as most promising?
Yeah. A very straightforward example is, but I think that's more Massimo's field, is of course combining ultrasonics with bioelectricity, so biosignals.
Yeah. So, for instance, in pregnancy monitoring, if you think, we have done a lot of work on electrophysiological monitoring of pregnancy. However, there are some weeks in which the vernix caseosa is a membrane that forms, actually isolate the fetal heart from the outside. Ultrasound can easily pass through, but not electrophysiological signals are more difficult to detect. So I think the combination of the two actually can be sometimes redundant, but certainly result in a more robust solution.
So this would lead to a multimodal digital twin, where several clinical partners could contribute to.
Yeah, absolutely.
One other question, and then I think we still have 5 minutes. What's the wavelength range you use in the photoacoustic approach?
Well, that's it starts in the visible range, so what we call red up to purple violet, all the way to roughly, let's say 2,000 nanometers. So 400 to 2,000 nanometers.
Okay. Yeah. And then there's a subsequent question: is the response contraction from the body dependent on that wavelength?
Sorry, is the what?
Is the response? The contraction, the whole, the generation of the ultrasound wave, is that dependent on that wavelength where you use the stimulus for?
No. So you send light with a certain wavelength that's being absorbed. Then that object collapses, you generate an ultrasound wave, and the wavelength of that ultrasound wave is basically related to the size of the object.
Ah, yeah. And then how deep can you go?
Yeah, that's that's a good question. Also there on the transducer, in the transducer area, there are a lot of developments with micro-sensitive transducer materials that can depict these photoacoustic signals, because you have to understand, we send out megapascal pressures. Yeah. We receive kilopascal pressures with ultrasound, but with photoacoustics it's 100 Pascal, 200 Pascal. Yeah. So there is a lot of, there is a very low SNR in these images. So we need better transducers there, but also better light delivery and signal processing.
Repeated, I suppose. You have a whole
you can average.
Pulses,
of course. But then sometimes the frame rate of the laser can be an issue. But also their signal processing is very important. We work on techniques that actually can reduce aberration artifacts, as we call them, because of speed of sound differences, out of plane artifacts, also to enhance these images. And if you do all these tricks, so now I come to my answer. When I started with photoacoustics, the limit was 8 millimeters, and we have now done studies up to 2.5 centimeters. So, but we should go deeper. Yeah.
Well, I think that ends our webinar. The good news is that this webinar was on ultrasound, but not in ultrasound, so we could all hear it. And I'm sure it made a great impression. Thank you very much for your attention. We're looking forward for you joining us in the next webinar, because there's a whole series. Thank you very much.
Thank you.
Yeah, thank you for having us.
Thank you all. Yeah.